Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm Obstetrician Dr. Patrick Maloney.
Today we thought we would help everybody understand or, answer some questions that they might have had about the medical system when it comes to obstetricians. So, we want to talk about what else is your obstetrician doing?
So every episode of this podcast, we're talking about the work we do in obstetrics, looking after women in pregnancy, and there's other stuff that we do.
Yeah.
And I thought it might be fun to talk about that today.
And also to just, in America, an obstetrician such as Pat's called an OB-GYN as an abbreviation. Technically in Australia, tell people what the abbreviation here is.
We say O&G.
O&G, yeah.
Same means the same thing, just a different way of saying it. And it makes us smile. If people call us OBs or OB-GYNs, they've probably been on the internet too much.
Well, it's everywhere in social media. Everyone's referred to as an OB-GYN. Yeah. And in fact, sometimes we've even used it because it's becoming more and more what people are known as.
Sure.
But let's talk about the G bit. The GYN bit.
Yeah, so we in Australia and in fact throughout a lot of the world, obstetric specialists also train as gynaecologists, so that we're not only looking after pregnant women but also all sort of aspects of women's reproductive and pelvic health. And certainly the training qualifies people to do both. In reality, out in the working world, it depends on people's circumstances, interests, and the needs of their community as to how much of the other type of work that they would do.
And also a little bit on where they're located. If it's Vic, regional or Vic Metro or,
Yeah, so traditionally in Australia, the closer you were to the middle of a capital city, the more likely you would be to have a fairly a narrower focus of work because the numbers in your referral area were such that you could run your whole practice doing a narrower number of things. And then the further away, the bit more of a generalist you need to be. So in O&G, most commonly, if someone's a busy obstetrician, they may actually practice no gynaecology. They might have a narrow focus to their gynaecological practice, such as something like I do private obstetrics almost all the time, and a little bit of infertility. Okay, and so I see people with fertility issues. I'm involved in some IVF work half a day a week, and the rest of the time I'm looking after pregnant women and attending births. And then, working more regionally, we tend to do a lot of both, and I certainly have in my own practice quite a broad gynaecological practice as well.
And, there's a lot that say we follow some endometriosis because that's also one of the areas that you really are interested in. And there's a lot of people saying, look, if your gynaecologist also does obstetrics, that must mean that they're not as good as a gynaecologist that only does endometriosis.
Yeah, you do see that from time to time on the socials, and I think that's not a wise way to decide on your endometriosis specialist. Some of the very best people I've ever seen in the endometriosis space have also been obstetricians. I don't think that's a meaningful distinction at all, and it's certainly not one that applies in a regional area where the community needs people to do both. Some of us are really good at both.
Well, so, Pat, for you, let's say you're regional, so there's a split of, say, 50-50, would you say, obstetrics, gynaecology?
In my practice it is, that's right, yeah.
So your obstetrician may only do obstetrics. So these are all sort of interesting questions to ask that person. But say if your obstetrician only does obstetrics, and you've got a gynae issue, such as during pregnancy, I don't know, maybe there's a fibroid or whatever the gynae issue is, what would happen to your care?
Well, that person may actually have it in their expertise to advise you properly and to manage that problem, or they might call upon a colleague.
Yeah.
And sometimes within a group of specialists working in the same building, they'll have a number of people doing primarily obstetrics, and then a go-to person who does mostly surgical gynecology, and that they might say to that person, "Here's this situation. What should we do? Do you want to do it or should I?"
Yeah.
And get that advice. Yeah. It's easy if you do one thing for a long time to become very good at that, and then sometimes you think, I haven't seen that other problem for a while. Perhaps the management of that's changed. Perhaps I should be asking somebody else.
Yeah.
Yeah.
Another part of your job as an ONG is teaching, and when you're there teaching, you just light up. I suppose it's a bit like the podcast, isn't it? You like teaching patients about.
I see this as a form of teaching.
Yeah, that's right.
And I do like teaching, and I think that pretty much everybody in ONG is involved in teaching in one way or another. Certainly, if you don't have a formal teaching commitment with a hospital or a university, you are teaching patients. A lot of the doctor part of being called doctor blogs. That's a teaching honorific, and it's because our job is to teach people and about how their body works, how disease works, what treatments are wisely undertaken, and so we're teaching anyway. But a lot of us have got formal teaching jobs with hospitals or universities. So that can involve teaching at the basics end, like teaching for medical students, which I do enjoy. I think that it's nice to talk to people about the basics. It's nice to introduce young students to the specialty and to the things that we like about it. It's amazing how many doctors, when they grow up and choose their specialty, base that choice on having met pleasant people from within that specialty. Yeah. It seems ridiculous, but it's true. So we get an opportunity to talk to junior students about our specialty, about its unusual mix of medicine and surgery, and how we have come as a specialty over 100 years ago from a place of highly problematic outcomes for women to a place of excellent outcomes through development over a century or so of the science of obstetrics. And then there's also teaching in a more formal and practical sense for our specialty trainees. So that typically is a gradual process of supervision over their 6 years of training, from people needing a lot of supervision and assistance and demonstration of various techniques and things at the start, to them being highly capable doctors towards the end of their training, and a gradual removal of the need for supervision and instruction as their training progresses. And then there's also some teaching that we do for people who are fully qualified obstetric and gynecological specialists but are still developing their various skills and interests. So I'm involved in that a little bit as well, some clinical supervision and development of skills for junior specialists.
And if anyone's interested in who knows, they might be listening to this and thinking, actually, I want to become an obstetrician. So many people want to become an obstetrician at one point in their life, when they're going through pregnancy and babies and everything. So we did an episode with a senior registrar, Erin.
With Erin, yeah.
Yeah, and so go back and have a little listen to that. That we've had so much feedback from that, and
really?
Sort of prompted us to do something like this. So go back and have a listen to how Erin became or is becoming an obstetrician.
It's a reasonable commitment.
Yeah, it's a very big commitment, and I did want to talk about that because you talked about medical students. So there's medical students, then there's a resident.
Yeah.
Yep. So a resident is still someone that has finished their medical degree, or they're still. Yep.
No, they've finished their medical degree. They're a qualified doctor, but they're yet to enter into a training program for postgraduate training.
Yep. And if you're a public patient in a public hospital, you may see a resident.
Yes.
They may be the first person that you see.
Yeah.
Yep. And then they may get you to see the registrar in that specialty. Mm-hmm. Yep. And then that registrar might get a senior registrar, or they might go to a consultant.
Yeah.
Yeah.
Yep.
So that's kind of the levels in Australia.
Mm-hmm. Depending on how things are going and the complexity of your case and so forth.
Is that the same in everywhere in the world? Is that
give or take, I'm sure. Yeah. Certainly within the Australian system, which grew out of the British system, is very similar, give or take, to the system in North America.
Want to feel good more often in 2026? Hi, we're here for you. Move by Mamma Mia helps you fit movement into your everyday, giving you more of me time whenever you need it. From strength and cardio to yoga and Pilates, with workout plans that fit every space, every body, and whether you've got 10 minutes or 40. Start 2026 with enjoyable movement from just $9.99 a month. Mamma Mia subscribers get unlimited access. Head to move.mamamia.com.au and use MoveMe to get $20 off an annual subscription.
Next, I want to talk about the continuing medical education that a ONG does, because that's quite intense, isn't it?
Yeah, so you can't just get your ticket and then say, that's me, I'm not going to learn anything ever again. So we have a program of compulsory continuing medical education, which spans over the course of the year, and you have to attend lectures and conferences, or undertake online training, or operate with a colleague to share tips and tricks, or all sorts of things would count towards the program. But the attendance, but participation in it is not optional.
No.
Yeah, and it keeps people relevant and up to date. And that's not unique to our specialty. It's right across the board, and it's an essential part of maintaining confidence that the advice we're giving people is good.
And that is really strictly monitored through the sort of the body RANSCOG. I know, because I upload all your
You're ticking me off.
Yeah.
No, that's right. They're very strict about it. You can't get behind, and you must keep going to things. And look, it can be difficult. Sometimes you look at a conference that's near you and you read the program and you think that none of that is what I want to go and do. And then you find something that sounds fantastic, and it's a long way away.
Yeah, and you have to take that time away from your patients and your clinic, and travel, and that's not all that it sounds like it should be great. It isn't. It's quite boring. I've been on some of your conference.
You've got to enjoy the subject matter, and it's a commitment. They are a good opportunity to catch up with people and to see what's going on in the world. But it's a commitment, and it doesn't always suit us to be away. There's also something that's probably growing in the world of ONG, which is especially in gynaecology, which is the idea of a sort of a preceptorship, where you would go and visit someone else's unit, not for a day, but for a week or two. And especially if there's a unit where they do things very, very well, you'd say, fine, I'm going to go and visit you, see how you do it. Take all the tips I can. What equipment are you using? What exact procedures are you doing? How's your patient flow? How does it all work? And that's a developing thing as well.
Yeah, and I love seeing that, because people aren't hanging on to the knowledge that they've got. Like in your craft group, people want to share that knowledge.
They do.
Yeah.
There is a history, expectation that you'll be generous about that. So if you've found a better way of doing things, there's an obligation to tell everybody about it.
Yeah. Now, what your obstetrician also might be doing is some research.
Absolutely. So people are often involved in research, typically within big hospitals, big public hospitals in Australia, but occasionally elsewhere as well. And we're always very grateful if people are prepared to be involved in things like clinical trials. It's a big ask. if we don't know what the best treatment is for something, and we run a big clinical trial where we've got 2 groups of 1,000 pregnant women and half get treatment A and half get treatment B, and then we follow them up and see who did the best, that's a big ask, and we appreciate that. But if we propose enrolment in a randomised trial to people and they just say, well, just don't give me what's in the envelope, just give me the best treatment. We say, well, we don't know what that is. That's why we're doing the study. So that is really interesting. And typically in a big hospital that had a teaching program and a training program for young specialists and an affiliation with a university, all of those places would be involved in some sort of research. Yeah. So we had Jo Said on the podcast, and she's a leading light in obstetric research, and so if anyone's interested in what we do in that space, listen again to Jo. She's trying to work out the best way to treat diabetes in pregnancy and the effective antenatal steroids on diabetes and so forth. Yeah.
And we're doing our own research at our clinic, the Ballarat Women's Cohort Study.
Yeah.
And that's an affiliation with La Trobe University, and one of the biggest studies of women, and now open to anybody to join. So anybody listening to this podcast, I mean, man, we would love it if you joined the cohort study.
Yeah.
So as a cohort study, it is measuring data, and you can remain anonymous. It would help inform where research goes, and anybody can join it. So I'll put a link in the show note about that. So that's what we're doing at the Ballarat Women's Clinic, which is also what your obstetrician might be doing if any of Pat's patients are listening.
So collecting, with people's permission, of course, collecting data on their current issues and seeing how their women's health issues evolve with time.
Yeah.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get Unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Oh, hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
And that leads us into another thing that your obstetrician might be doing, which is women's health advocacy.
Absolutely. So we do like to be involved in this, some more actively than others. But the organisations that we're typically a part of, so RANZCOG is the training body in Australia who oversees training in our specialty, but they also have an advocacy role, talking to government and various funding bodies about what RANZCOG sees as the major issues and the major potential places where we've got for improvement, and to sort of take an issue like recommendation of whooping cough vaccination to pregnant women so that the baby comes out partially immune, and we can see the flow on of that in fewer and fewer babies getting sick with whooping cough in the early weeks before they can have their own vaccination. Then bodies like RANZCOG would be involved in the initial stages of saying to government, this is a good idea, let's lend our weight as a group of specialists to this recommendation, and government ideally would take that and say, terrific, if you think it's a good idea, we'll do it. And then there are some other bodies, professional bodies within O&G that do similar things in the gynaecology space.
Yeah, one of the things that we were really excited to see is the work that, with other groups, the collaborative impact of O&G's getting involved in the 3 gene carrier screening, getting onto the Medicare benefits. Yeah,
exactly. So that's the test we have available in Australia now, where you can, before you have a baby, you can find out whether you're a carrier for serious genetic diseases, and if you are, your partner can be tested to make sure that you both don't have a problematic gene that could be passed on to the baby in the form of the major form of the disease, and that. Just to test for the 3 biggest, most common genes on that test was cost $300 or $400. Eventually, through a process of advocacy, it has been covered by Medicare, and it costs people nothing.
Yeah, bulk bill. That is just everybody should be going out and having their 3 gene carrier screen. I think it's called 3-panel screen. Yeah,
and if you've had one baby and you haven't had it, go and have it to shed some light on your risk.
Oh, and that's exactly right. So it's not just for people that have never had babies. You can have it in between babies.
For sure, and you can have it while you're pregnant with the first if you've missed the boat to get the test. Doesn't matter, because it's still relevant to future pregnancies. And that's just a great example of something where the major barrier was not the technology, which presumably was the hard bit. It's cost.
It's cost.
Yeah. So the decision was made in Australia that was worth funding to help people understand the issue and presumably lower the number of cases.
There's still lots of areas of women's advocacy, health advocacy, that we are passionate about, but you wanted to mention about the private health not having an exemption for pregnancy.
Yeah, one of the things that still gets my goat, and I know that various groups, including NASOG, which is another group that supports O&G issues within Australia, are passionate about is that there's a sort of a rule in Australia that if you've got private health insurance that covers all sorts of other things, it doesn't cover you for pregnancy care unless you've alerted the insurer in the first place and then waited a year. And people get caught out all the time through pregnancies that were unplanned but proceeded with, or through underestimating their own fertility and assuming that if they let the fund know I want to be covered in 1 year and then get pregnant the next day. Then obviously there's not time, and the issue as a lot of ONGs see it is that there are some ethical problems with that. Chiefly that a surprisingly large number of pregnancies are unplanned.
Yeah, more than half. Yeah,
because comfortably more than half. And that's not to say that people don't proceed with those pregnancies. They do, but they were still essentially unplanned. So that there's an unreasonable burden on that couple who've done the right thing by taking out some insurance but are shut out from claiming for something that could always have happened to them. Whereas if they had another health issue that wasn't pregnancy, the 1 year system doesn't apply.
Work, yeah.
The only things that do apply are things that were already wrong with you are shut out for a year. But if you take out insurance and break your leg the next day, that is covered.
Yeah, it's crazy.
But the event of breaking your leg may have been just as unpredictable as the event of getting pregnant. And there's also a gender equity issue. If a couple have intercourse and there's an unplanned pregnancy as a result of that, the burden of that contraceptive failure rests vastly more heavily with the woman than it does with the man, both in healthcare but also expense, time out of the workplace and so forth. And the system is not respecting that, and the insurance loophole does not recognise that. Yeah.
All right. So if there's any policymakers,
anyone's out there listening, we'd love to see that correct.
Yeah, that is a big bugbear. So all of that makes your obstetrician quite a busy
person. Yeah. So it's a very rich specialty, and there's a lot in it.
Yeah.
And it's a job that you don't have to pick a narrow part of. There's lots of different aspects to it, and it makes it highly enjoyable.
And especially in a birth space where there are lots of different birth professionals, obstetricians are sometimes quite achievers. They're there because they are passionate, and they're passionate about women's health. Yeah, and I find it's been a real privilege for me to meet so many of them.
Oh, that's good, because sometimes the role of the obstetrician can get criticised in popular discourse about it, that we are overly interfering in the birth space or something like that. Whereas I have never met a single obstetrician who signed up to such a long period of training, study and development of expertise just to cause trouble.
Yeah.
There are people, in my experience with the well-being of women, which is a marker of the well-being of our community, in broader community, absolutely at the heart of everything they do.
Oh, yeah. And I think we've got that on our website, that women communities are only as strong as the strength of their women.
Yeah,
I think it was Michelle Obama that said that.
Yeah, there's so many times that's been proven again and again in developing world space, in just the idea that if you address the health of young women, that has this amazing flow on to the general quality of life of the whole community.
Yeah. Us women, we're amazing.
You are.
All right, to all our amazing listeners, thank you so much for joining us on this episode. We love having you on this journey, and we hope that it's helping you have a very healthy and happy pregnancy and birth and move into your motherhood. So that's it for us for this week. We'll be in your ears next week. Until then, thanks so much.
Thanks for listening, everybody.
Bye for now.
Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.